Dr. Moshe and the other dignitaries on the dais, ladies and gentlemen, it's a long time I have distanced myself from the professor of medicine. But I hope one doubt what I had in my mind, whether today's oration is confined to the pediatric epilepsy or how to find the epileptic seizure. If it is adult, we can always ask the patient, what do you feel, anything before the answer. But in pediatrics, how are they going to ask the kids as a feeling? But anyway, we will understand, we'll come to know when we go through the speech by the Dr. Moshe. So, I don't know, this is a good old hundreds and I don't know how many years this particular disease persists with all the researches and all. Still we have not been able to pinpoint why it causes, where is the focal. Anyway, the research should go on. There is always a race between the man and the God. Now we will come to know whether we have found something where we can be free and comfortable without the epileptic diseases. Now, one thing, what I am surprised to see, there are more number of pediatricians in the today's thinking whether they have come across with more of such cases or it's any ordinary pyraxial fits with confusion with the epilepsy. Anyway, let's hear something and enlighten ourselves with the doctor.
Thank you very much, sir. Can I request the dignitaries to grace the seats of the dais? So we'll move on to the most awaited part of the event, epilepsy and seizures, challenges and road ahead, by none other than the speaker of the day, Dr. Solomon Moshe.
Hello. Yeah.
Okay. Thank you for giving me the honor to give this oration. There isn't many times that you have the chance to honor people for what they've done. And what Dr. Patel did rings a true bell in my heart. It's amazing to be able to say from the Bible, honor thy parents. And it's best to do it when they can hear how wonderful they've been, and they can watch their wonderful daughter navigate through pediatric neurology and creating the new field in your area. You can notice that the Isabel Rapin Department of Neurology, Isabel Rapin was my teacher, and the reason that I went to Einstein. And about 2005, I created a symposium to honor Isabel Rapin. They asked me, she's alive, why are you doing it? And I said, because she's alive. And now we have to hear what people are saying about us. So I don't think it's the greatest honor than what Dr. Patel did for Sid and Shell, and I am truly privileged to give you this lecture. Thank you so much. This lecture is supported by different funds, etc. And sometimes I'm gonna go fast and sometimes I'm gonna go slowly. The most important thing is here is that the patients have told us the stories that we hear, and we try to understand what's all epilepsy. And also they help us create the opportunities by providing funds. And EpiTrust is doing this for India. We've been doing that for several years now. I think it's almost 15 years that Sunita had the idea of creating the EpiTrust. And it's really amazing the people who have reached. The teachers, the kids, everyone. And thank you, Sunita, for really taking the lead and doing this. Please, can I have a round of applause for... Now, I'm going to give you a lecture that some of you are going to think that it's maybe too scientific. Maybe you can think it's too simple. But in reality, it's what expresses what I think should be doing when we think about learning. And I'll start with the model of epilepsy described as kindling. And what kindling is, it was taken by Goddard in 1967 to describe a process of epileptogenesis. It turns out what kindling is you take a stick and you light it and you put it in the fire, and then a big fire gets, and a bigger fire, and a bigger fire. And Graham Goddard noticed that there were some animals that in his experimental studies of self-stimulation, where the rats stimulate, and they're happy. But some of them had seizures. And the investigators of the time threw the animals away. They were disrupting the experiment. Never do that, because there is some reason for why this is happening. And what he thought is that this could be a way to find out how this stimulation at the beginning did nothing, and then eventually created focal seizures, and then bilateral seizures could be a model of epileptogenesis. And he found out that the effect was long-lasting. Now here is the emphasis, because besides talking about seizures, we have to think that this is a model of acquiring knowledge. And I want you to think, I don't know if you do it anymore, about your multiplication tables. How do you learn the multiplication tables? By repetition. 1 times 1, 1 times 2, 1 times 3, blah, blah, blah. That's the same thing that the brain learns how to memorize things, and sometimes it has the side effect, a seizure. So there is a model of learning and memory. And the effects are long-lasting, but they can be modifiable. And then there is a term that I introduced that's called rekindling, which means you reassess the information, because not everything that Nico Moshe is going to tell you today is necessarily the final word. And please, the people who come after me, you should be able to say, let's modify it because we're going to learn something new. This is rekindling. And what you see in the bottom is the time that I was a soccer coach with a bunch of, at that time they were 9-year-olds, and I had them till about 13-year-olds, and they became wonderful soccer players. That's another form of kindling and rekindling. The person who helped discuss kindling more than anyone else, besides the original discoverer, Graham Goddard, was June Wada. June Wada passed away last year. Many years ago, he shared these thoughts with me, which I think is the most important message for you back there. Okay? Are you paying attention, you back there? And what does it say? The future is all yours for the creation of new knowledge and the exploration of the brain. Never forget that. We need you to rekindle the information that we created for you, as we rekindle the information that was before us, so we can keep on going and going. So along these lines, I'm going to give you quite, and maybe for me it's an interesting story about seizures, epileptogenesis, and epilepsy. And we're going to discuss what is a seizure, what is epilepsy, age-related phenotypes and epilepsy syndromes and etiologies and pathologies, and then all the other stuff that you see below that. And this talk emphasizes seizures early in life because we tend to see a lot more seizures early in life, or so we thought. Actually, there are two times that we see a lot of seizures, very early in life and late in life. Most of the studies were done in the younger people, and that's where my interest was as a pediatric neurologist. But as I'm approaching the age of the other end of the spectrum, I like to know why older people have seizures. And I can tell you something that is very obvious. The reason that we knew that there were a lot of seizures in the baby brain is because we had neonatal ICUs. The babies came out, they didn't look right, and we start looking at them. And then we stuck an EEG on them very early on, and we capture the seizures. We don't do that for the adults. We let them be away. And we don't put the EEG as much as we do. But if we did that, we will find out that some of the same causes may be applicable to the other end of the spectrum. But there are differences. So what is a seizure? A seizure, you mentioned that we do not know much about epilepsy and seizures, and it's still true. What we consider seizure is a transient occurrence of signs and symptoms that they are associated with an abnormal, excessive, or synchronous discharge in the brain. It's not the only thing that's asynchronous, and it's not the only thing that it is excessive. You can see a lot of other neurological conditions that they have the same applicable rule. But we don't have another better definition at this point. What characterizes the seizure is its abrupt onset and its abrupt termination. Sometimes lasts for a longer period of time. And we know that it may be associated with a lot of firing of the neurons. And we try to modify that by giving medications. How many of you here are pediatricians? Thank you. Thank you for raising your hands. All I'm asking you, is to remember that if you see a seizure, you need to try to classify it if it's focal or generalized or unknown. But how are you going to do that? You need to see the beginning. Okay? If you do not see the beginning of the seizure, you cannot classify it. And why is this important? Because from epidemiological studies, we think that every baby has a generalized tonic-clonic seizure because that's what we see later on. The important aspect is the beginning. So if you have not seen the beginning of the seizure, please do not say that the child had a generalized tonic-clonic seizure. Say, I don't know. Be humble. I do not know the onset. So we have seizures that they start focally, and as you mentioned in the introduction, an older person can tell you, I feel something funny, I have funny taste, etc. The baby cannot say that. So you're going to see the bilateral manifestations very quickly. So lesson number 1, do not classify the seizure, diagnose the seizure type unless you know the beginning. And if you are not sure, you can use a piece of equipment that you all have in your hands and ask the parents the next time they see the event to take a video. Then you can see what's going on, especially when the behaviors are such that you do not know if that's a seizure. Please do not diagnose more seizures than they are necessary. Now, what is epilepsy? Epilepsy is having 2 seizures, unprovoked seizures, that doesn't happen because there is an infection or fever, that they're separated by 24 hours. Why 24 hours? Have you ever thought of that? The reason for that is because Alan Hauser, in 1976, decided to use that term in order to determine the occurrence of epilepsy. And because he thought infections may last 24 hours. But infections don't last 24 hours. So if you have an infection and you have 2 seizures separated by 24 hours, it's not epilepsy. You do not have any provoke event. Also, you can define epilepsy if you have an unprovoked event or a reflex seizure that's associated with a syndrome, and I'll discuss some of the syndromes later on. That you can say the person has epilepsy. And then sometimes when the baby comes to you or the young child, you know it in your stomach that this person has epilepsy. How can you quantify that to the people that you're teaching? So in the task force that I was part of, we created a mumbo jumbo of words. Now remember that. It is the chances of having another seizure is at least 60% after 2 unprovoked seizures occurring in the next 10 years. So if you have 1 seizure and you think that the chances of developing another seizure over the next 10 years is more than 60%, you can consider it epilepsy. You understand that? Now, can I translate it to you? If your stomach tells you that this person may have epilepsy, then strongly consider it. Okay? Forget the mumbo jumbo. And once you have a seizure, you have to think of classifying the seizures and the epilepsies. Now, this is an important slide. Do I have a pointer? No. I'll use this. The seizures can be as we said, focal or generalized or unknown onset. And then you can have epilepsies, which are the type of seizures that you may have. They can be focal, they can be generalized, or they can be both focal and generalized. And some of them, if the seizure, you don't know the seizure type, it's unknown. We also have the epilepsy syndromes, which are conditions that they have a certain prognostic value, which is important to tell the people once you make the diagnosis. You also have two other important points. That the seizures do not happen without other comorbidities in the brain. Sometimes we're lucky and the kids are absolutely fine, but they may also have intellectual disability, they may have ADHD, they may have depression, they may have a lot of other things. So diagnosing epilepsy does not mean you have to forget that they are comorbidities. That's very important. The other is here, and that's key. A seizure is a symptom. We need to know the etiology of what is causing the seizure. And right now, the causes can be structural, they can be genetic, and about 20 years ago, we knew very little about the genes. Now we know a lot more. They can be infectious, following an infection, not acutely. They can be metabolic. Immune etiologies appeared in the middle of the first decade of the 21st century, so this is new. And then we have unknown. There is a task force, and Elisa Yosevitz was member of that task force, led by Ronit Pressler, who tried to define what is happening in the neonate. And the neonate, when we talk about seizures, please remember that in the neonate, all the seizures are focal. And that's easy to identify because you have the EEG, most of it. But all the seizures are focal. You do not see generalized seizures from the onset in the neonate. And then in order to make sure that what you observe is a seizure, you need an EEG. Without the EEG, you trust your instincts as much as you can, but you need an EEG, and you can have electroclinical or electrographic only seizures. And then you may have an epilepsy syndrome. Again, see, you need to figure out what the comorbidities may be. And the etiologies are the etiologies of hypoxic ischemic encephalopathy, which is the most common cause of having acute seizures in the neonate, structural, which is vascular or brain malformation, and again, all the others. What I would like to submit to you, that this is applicable in any age with acute seizures. If you have a 70-year-old, the most common cause of having a seizure is an acute hypoxic event, with stroke being the highest probability, and the same approach that we use in the neonates should be used in every age group. Now, what is the syndrome definition? It's a characteristic cluster of clinical and EEG findings that have specific etiological findings, which can be structural, genetic, metabolic, immune, etc. If you make the diagnosis of a syndrome, it carries a certain prognosis and treatment implications. And syndromes often have age-dependent presentations with a range of specific comorbidities. So if you diagnose a syndrome, you have a step further from diagnosing epilepsy. You know maybe what you're treating. And please remember that you have three kinds of syndromes. One is associated with seizures that they stay for a certain period of epilepsies, that they stay for a certain period of time, and then they disappear. These are self-limited epilepsy. We don't call them benign anymore because they may have comorbidities, and the comorbidities will stay. It is benign, the seizures may go away, but the comorbidities may not. You have syndromes that you have a very specific etiology, and you have syndromes that they are associated with a developmental encephalopathy, and I'll talk about it in a minute. There is a series of articles that they were published a year ago in the journal Epilepsia, and these are the proposed syndromes that we put together in the neonatal, infantile, and child, and also some that they have an onset at any age, and then the idiopathic syndromes. And you see how much time I spent discussing these slides, because that's not the way to approach it. What you need to do is read it, think of what you may have, and then when you have your patient, go back and look at the article. And for you younger guys that use the computer, There are big tables there, and one says features that are obligatory for the diagnosis, features that they may allow you to question the diagnosis, and features that are against the diagnosis. Pay attention to the columns. Don't look for the word, and if you find it there, you know that it's the syndrome, because that's not the case. Okay, guys? Computer mavens, you have to read what is written there. That's the best advice I can give you. And anytime I work with my residents, I force them to read very slowly so they can understand what the article is all about. Okay, the second group of questions that we're going to discuss is developmental. I will not discuss aging processes that may influence the epileptogenic mechanisms, either positively or negatively. We do not know that yet. How do seizures stop? Most of the times we're lucky and the seizures stop after a certain period of time. That's the best thing that we have about epilepsy. We don't want the seizures to go forever. And what are the different consequences of seizures and the outcomes? And how do epilepsy stop? We don't know some of these questions, but we'll address them. This is a slide that I would like you to think about what is the process of epileptogenesis. So usually we have the first seizure, but it may be an initial precipitating event that may produce the seizure, because not always it does, and that may be related to the genetics of the presence of an abnormal brain, also the age of the person, and a factor that we need to determine much more is the sex, because there may be difference between males and females. And then the first seizure produces some structural and functional changes that may lead to the development of epilepsy, which may produce more changes. And some of the epilepsy will be responsive to drugs, some of it will be refractory to drugs, and some of them, even if you have those changes, they go away. And this is all associated with a combination of factors that I already mentioned: the underlying pathology, the genetics, the age, and probably the gender, the sex. One of the papers that you will see in the literature is that, and I'm partly responsible for that when I did my first studies, is the immature brain has a lot more seizures because it's more prone to have excitatory processes and less inhibition. This is not true. And what this slide shows is this theory that you have a lot of excitation and decreased inhibition, but I wish the data that we have suggests that. And the data that we have is that every part of the brain is different, and in some areas excitation precedes inhibition, in some other areas inhibition happens before excitation, and the mechanisms that produce the seizures can be very diverse. There is another thing that's very interesting to remember. Again, it's a little bit sophisticated, but we know that the main neurotransmitter in the brain that has inhibitory effects is GABA. And that is because it produces a hyperpolarization of the membrane. In the very young brain, the GABA application produces a small depolarization, and some people consider that an excitatory mechanism, but it isn't. It does not produce any action potentials. And what is this mechanism? It allows for the continuous entry of calcium into the cell that allows the brain to mature. Every part of the brain has a different time that switches from the depolarizing to the hyperpolarizing effects. Some people say that the cortex matures after than the subcortical structures, and that's why you have seizures in the neonate. But that's not the case. For example, the substantia nigra matures much later than the hippocampus. And also, there are sex differences in this that may account for these changes. So there is a lot of work to be done to try to figure out why the immature brain will have seizures. There are several studies that show that changes in the brain happen, that they have specific temporal and qualitative approaches, and some of them will go away, and some of them will stay. And we do not know that. But this paper, published a year ago, is an atlas that shows you the lifetime of certain proteins across the mouse lifespan. We don't have it for humans yet. Okay, so we have no clear idea why the seizures start still. We know that there may be an imbalance between excitation and inhibition, but we don't know exactly what happens. There is also, some of the seizures don't stop. They keep on going for a long time. And there is a practical definition of status epilepticus that suggests that it's a failure of the brain to contain the seizure till it leads to the development of brain damage, which is T2, the time T2. That was established by adult epileptologists. And why is this important? It's important because this does not happen in the developing brain. Now, it turns out that back in the 60s, there was an English neurosurgeon who thought that mesial temporal sclerosis was the most common type of epilepsy, which is not true, but he believed on that. And then he said, what causes mesial temporal sclerosis? And he said it's hypoxia and ischemia early in life, or a febrile seizure. And the hypoxia and ischemia for you pediatricians was an APGAR of 6, which is not much of hypoxia or ischemia. It turns out that probably this is not true, that no, the febrile, and I'll show you some data about febrile seizures later on, but hypoxia and ischemia, at least in the developing animals, does not produce the injury. And if we did the experiment that we induce seizures in baby rats and rats of different ages, and what you can see is that if you have an adult animal, you develop a lesion. That's what this cell loss shows you here in the adult hippocampus, in the CA1 area. But if you do the same thing in a baby, you do not see any changes at all. And you do not see any synaptic reorganization. Now, this is in a normal brain, which may be applicable to a kid that had a febrile seizure, and it's totally normal. It does not mean that they're going to develop epilepsy because they had a febrile seizure. In some models, you can see some changes that shows the difference between the genetic factors that you may have. And having seizures may have comorbidities that may affect how the kids learn. But this is not the reason that they will develop intractable epilepsy later on. And we need to understand the genetics. Dr. Patil mentioned the FEBSTAT study, which is, we took 200 kids that had complex febrile status epilepticus, prolonged, and we did MRI imaging and EEGs. And what we found is that soon after the seizure happened, the EEGs were abnormal. Most of it showed focal slowing. When the study was done, we were not fully aware about Dravet syndrome, but we saw some kids that have epileptiform discharges after status epilepticus, and all of them ended up having Dravet syndrome. So if you see acute epileptiform discharges, spikes and slow waves, this is associated with a genetic encephalopathy. And to make the long story short, we found out that less than 10% develop changes in the hippocampus. Febrile seizures tended to delay the growth of the hippocampi. It's not good to have a lot of seizures. We do not know what the meaning is. But the chances of developing epilepsy after 10 years was about 10%. Very small. Okay? How do seizures stop? We don't know that either. And there are several mechanisms that have been proposed, and this is a slide that suggests some of this mechanism. You can find this information in a paper that Fred Lado wrote in 2008. And there are mechanisms acting on a single neuron, or a mechanism acting in a combination of a network of neurons, and also in areas that they affect the expression of seizures. and I'd like you to think about this, is the mechanisms that they actively involve include the thalamic nuclei, the substantia nigra pars reticulata, and the subthalamic nucleus. And the reason for this is important is because this is the areas that we go after when we do deep brain stimulation. And an interesting paper was published last year by Fred Schaeper, and he showed that if you put together all the structures that are associated with a seizure, the substantia nigra pars reticulata is part of the circuit. That was music to my ears because I spent a lot of time studying the substantia nigra pars reticulata. And what we did is we infused drugs in the substantia nigra, in the anterior or posterior part, in different ages. And if you are an adult person, a male person, there are two regions. One of them that has anticonvulsant effects. Anything above the flat line here, the horizontal line, is an anticonvulsant effect, and anything below is a proconvulsant effect. This is a male, normal male rat, and you see that the effect, the anticonvulsant effect, appears about adolescence, and very early on, no matter where you put it, produces proconvulsant effects. And then there is also a region in the back of the substantia nigra that's proconvulsant. If you look at the experience of females, it's totally different. There is no proconvulsant region, and the anticonvulsant region develops earlier, suggesting that hormones play an important role. And what makes a boy is that about the first day of life in the rat, it's a lot of secretion of testosterone. So we did an experiment that I do not recommend to do in kids who have intractable epilepsy or have hypoxic ischemic seizures. We performed a neonatal castration. So I don't think you can do that to your boys if they have seizures. And you can see that if we change this, you develop the female phenotype, which shows that the substantia nigra can control the seizures much earlier. Again, oops, what happened? Again, the important message is that there are hormones that may be involved in the expression of seizures, and testosterone, which is metabolized to estrogen, may play a crucial role. And we use that for different parts of the brain to provide stimulation. It turns out that one of the areas that the substantia nigra pars reticulata produces the effects on seizures, besides turning off everything that I do, is affecting the pulvinar. And now there are studies in humans that you can produce stimulation of the pulvinar and you can suppress seizures. The other areas are the subthalamic nucleus and the thalamus, all areas that the substantia. What other treatments we have? Well, we have medications, different effects on the developing brain than in another brain. They are drug-resistant epilepsy, and we have non-pharmacological treatments, anti-epileptogenic treatments that allow you to stop the process of epilepsy, and treatment of comorbidities. Now, this is a slide that I got from Dr. Sunita describing the development of anti-seizure medications over the years. And we started with the bromides, phenobarbital, primidone, ethosuximide. And please note that all of these drugs were first developed for the adult brain and then were used in the babies. And some of them are terrifically effective. So, for example, which is the most effective anti-seizure medication that every drug company is scared of? And they don't want to do studies against that medication. Phenobarbital, okay? And if they cannot do it, they will say, oh, it produces side effects. It produces apoptosis. Well, if you have to think about how many people got phenobarbital in the 60s and the 70s, that may be an explanation why in America we have a problem with the government. But I don't think it's an issue. More recently, we start developing drugs that they are first tested in syndromes in babies or young kids, and then they will be used in other age groups. And some of them include clobazam, which, by the way, you used here long before we used it in the United States. And supposedly it has no side effects, but we also know that it has side effects because you cannot give too much GABAergic drugs. There may be a degree of apoptosis, and it has a horrible rash that was missed. Cannabidiol, stiripentol, fenfluramine, and ganaxolone. So now the approach is to take patients, and they're very important that we have patient organizations that they tell us the stories of the kids. They get all together, we talk with them, and we try to find treatments that specifically affect them as the syndrome that they may have and they may work. So for example, ganaxolone is a medication that works very well in encephalopathy, CDLK5 encephalopathy. Now they're looking to find ways to see if it works in other forms of prolonged seizures, such as status epilepticus, but all started from the genetic model. So how do we develop this? Serendipity is the first thing. You give something and you notice that it works. Remember what I told you about kindling. Most investigators ignore the seizures. If you don't pay attention to the mold that you have in the surface of the agar plate, you will not discover penicillin. If there's something out of the ordinary, follow it. Follow your nose. Follow your instincts. Then we screen a lot of drugs. We begin to design drugs. We repurpose drugs. So, for example, quinidine is being used for alternating seizures, the syndrome of alternating seizures early life, immunotherapy, and genetic modification. And the next slide, which I will go very quickly because, again, I think Sunita gave that to me. It gives you the different ways that the drugs work. Allow us to discover some drugs. More of those. You see how many we are there. Now, the idea is that because only 50% of the kids with hypoxia ischemic encephalopathy responded to it. Well, it turns out that they didn't do similar studies in adults because the response of adults in status epilepticus to any medication is about 50%, so it doesn't make any difference. The other thing that's very important is that, we tell you doses that you can use. So how much is the dose of phenobarbital that you will use to stop seizures in the baby? 20 milligrams per kilogram, right? Who invented that? Well, when I started, it was 5 milligrams per kilogram. Within 5 years, it was 10 milligrams per kilogram, and then went to 20 because Jack Perlock said 20 milligrams per kilogram. No data. But what's important is that you have to give enough. You have to give enough that doesn't cause toxic symptoms. And this slide here, in a study that we did in the laboratory with Dr. Hassan, what we did is we gave high doses, and we were able to suppress, and an hour after the onset of status epilepticus, and we were able to suppress it by giving pentobarbital or diazepam. So as long as the baby is breathing and the heart is working, you can give higher doses to stop the seizures, and please don't keep on changing one medication to another. There is an exception to that I want you to remember, that if the seizures start on the 3rd day of life, it's a possibility that these may be seizures responsive to sodium channel blockers. It's a genetic abnormality, and these are phenytoin and carbamazepine. Everybody talks about carbamazepine. Do you know why they talk about carbamazepine? Because the study was done in Italy, and in Italy they don't have phenytoin. So they gave carbamazepine, so we think these are carbamazepine responsive seizures. They're not. It's seizures responding to sodium channel blockers. If there is a gain of function mutation, we need to separate that too in the sodium channel, in the potassium channel, I'm sorry. In the lab, what we have done is, and Ariste Galanopoulou has done that, she has created a model of infantile spasms, and she checks different drugs, and we have identified several that may be of interest. One of these is rapamycin, that seems to be quite effective in the control of the spasms. There are also gene therapies, and this is a study that, a paper that came out last year, and there is a study that you can genetically modify patients with Dravet syndrome, and the study is called Tango, and it's currently in a drug trial where you provide the gene therapy, you change the mouse, the brain of the mouse, and the seizures go away. Other approaches that have been used is what we do very well, high throughput, de novo association of ligands, etc. All of them is very good, but it will take time. AI may help us with that, but AI needs somebody to talk to AI, which is us. Don't give up what you have. You are the drivers. The same way, do not give up what you are as doctors to administrators. Okay? And drug-resistant epilepsy may require different kind of approaches, and we proposed a lot of ways to redefining to make it more effective. We have also non-pharmacological treatments, which is surgery, and the reason that we define drug-resistant epilepsy as a failure of 2 adequate trials of anti-seizure medications is because you would like to see if the patient can have resective surgery that may improve the outcome. Vagal nerve stimulation has been used. Deep brain stimulation of the anterior thalamus and the centromedial thalamus, as well as responsive stimulation. And I already told you the rationale about affecting those structures. But remember that it's not going to be easy to develop all the treatments that we have. Because as I showed you much earlier, when you have an insult, a lot of changes happen, and you may have targets that they occur at different points. And we need to investigate that. The NIH put together a group of investigators in the Center of Without Walls, and the purpose of that is to try to define ways to control the seizures early on, to develop new anti-epileptic therapies. And also, we have to address the comorbidities. As part of what we did, we need to figure out how we can predict seizures. And here is a study that describes that there may be association of different cycles that the seizures occur. Some seizures occur at very frequent intervals. Some seizures may take years, etc. Some may occur at night, etc. We need new mechanisms to allow us to do that. But the real issue is, for everything that I said up to now, I've left something out. I talked to you as a clinician. I talked to you as a basic scientist. What is the group that I left out? What are we celebrating here? What did your parents do? The patients. And do we hear what the patients say for us? So the person with epilepsy has a lot of issues. Some are the medical issues that we would like to discuss. But look what is interesting to me. Education, work, family impact, peer relationship, motility and driving, expectations, and after we talk to them about SUDEP, they want to know about that too. So as we move forward, we need to hear from them. We need to develop treatments that they take their needs into account, not only what we think should be done. And the EpiBIOS program that I mentioned to you before, that Center Without Walls about post-traumatic epilepsy, created a public engagement core. And that's very important. This is the mechanism that we have to do. Doctors and patients. Listen to the patients, they're always correct, and then modify what we do. So what we do about the people with epilepsy, we can do something at the individual level. As to the person, also the health provider, but also we have to do something at the society level, within a country, internationally, and the step that we do here with the Epi Trust is to try to talk to teachers, etc., so we can discuss with them what the implications of having seizures. How are we going to change, though, what's happening? Most of the people who make the decisions about medical care do not care about epilepsy. And the reason they don't care about epilepsies are they're scared, they don't like to see it, and the second, it usually affects young or people who have intellectual disabilities, and they cannot go to the president and say, or the Congress in the United States and say, give us more money. They can't. We have to speak for them. And there was people that they can champion that, and the Axelrods had a daughter who had epilepsy. It happens that David Axelrod was the most close consultant to President Obama, and during these years, we achieved certain things in the US in terms of epilepsy that we didn't have before or after. But then they're gone. So we need new champions. So I took you through a group conditions related to epilepsy where I emphasize what is happening in the expression of seizures as a function of age, how from basic science we can understand that. But I would like to leave you with a final thought. And the final thought is, it is not your duty to finish the work that you started. Work is not everything, but neither are you free to neglect it. That means you have to share your ideas with people who can follow you, and they can keep on doing it. This is not one person's work, it's a team effort. Now, individually, you think that you failed, and I like to read to you verses from my favorite Greek poet, which is named Kavafi, and it tells you that arriving in Ithaca, which is the goal, it's not the important thing. Always keep Ithaca in your mind. To arrive there is your ultimate goal. But Ithaca gave you a beautiful voyage. Without her, we would never set out on the road. And the road is more important than the end. Thank you so much.